I'll be talking about adrenal insufficiency, hyperadrenalism and glucocorticoid excess, and also congenital adrenal hyperplasia. I'll start by going over a little bit of the physiology of the controls of the adrenal and the pituitary in relation to the hormones produced by the adrenal. At the base of the brain is the hypothalamus, as you all know, and the hypothalamus sends the peptide signals which control the output of the anterior pituitary. The particular peptide signal which is important for the production of cortisol or hydrocortisone is corticotropin-releasing hormone. And corticotropin-releasing hormone released by the hypothalamus travels through the vascular network of the hypothalamic pituitary axis down to the pituitary, where it stimulates the release of ACTH. ACTH from the pituitary gland then stimulates the adrenal glands to produce their hormones. Cortisol is essentially 100% under control of ACTH under normal circumstances, and aldosterone, which is the major mineralocorticoid, or the hormone which controls salt and water balance produced by the adrenal, is about 30% controlled by ACTH. The other 70% of the control of aldosterone is based upon the relationship to the renin-angiotensin axis. There's also a feedback relationship in that cortisol produced by the adrenal feeds back not only to the pituitary gland, but also to the hypothalamus to shut off production when there is enough circulating cortisol around. And in the same way, ACTH also can feed back to the production of corticotropin-releasing hormone. Now, the adrenal glands, as you know, are very complex factories, and they're actually composed of two distinct parts. The adrenal cortex is the outside part, sitting right on top of the kidneys, and in the center of the adrenal cortex is the adrenal medulla. I'm not going to be talking about the adrenal medulla, except very briefly. The medulla is responsible for producing catecholamines, and is also the reason why adrenals can be beset by neuroblastomas and pheochromocytomas. The only important thing about the medulla that you should be aware of is that in congenital adrenal hyperplasia, when there's disrupted production of cortisol, apparently there's some anatomic disruption of the medulla so that there is less epinephrine release, and this can lead to a hypersensitivity to hypoglycemia with fasting or stress in individuals with this condition. The adrenal cortex itself has an anatomic structure. On the outside is the glomerulosa, and the glomerulosa is really composed of the cells which feed down to the mineralocorticoid pathway, leading to the production of aldosterone, the major mineralocorticoid. The next layer is the fasciculata, and the fasciculata in red on this chart is the glucocorticoid pathway, and that leads to the production, by and large, of cortisol or hydrocortisone. The next layer is the reticularis, and that's the innermost layer, and that's basically the weak adrenal androgen pathway. The major adrenal androgens are really protoandrogens. They are dehydroepiandrosterone and androstenedione, but they are converted to testosterone, and testosterone can be converted to estrogen, so that all of these steroid hormones can be produced within the adrenal gland. I'm going to begin with a case presentation just to get your mind set for the kinds of problems we're talking about. This is actually a patient I saw many years ago, and I will continue the anecdote a little bit more after I'm done telling you this story, because it even has a sort of an interesting ending. A 10-year-old boy was sent to the emergency department of the hospital that I was at because of severe vomiting associated with a school phobia. And this was not his first trip to emergency departments, but it was the first time someone had gotten around to doing more than just giving him IVs and sending him home. He'd actually had some blood chemistries performed. For the past year, he'd refused to go to school most mornings, saying he was too tired and his legs hurt. This is the third time he came in because of intractable vomiting. On examination, he was dehydrated, and his blood pressure was 80/40 with a pulse of 110. He was alert, but he said his muscles and his stomach hurt. He was normal height and was quite thin for his age. He was a Caucasian boy whose parents were a mixture of Irish and German heritage. But when I saw him, I noted that his skin had a slightly grayish-brown pigmentation, particularly on the knees and elbows. And this is not a picture of his hand, but it's another hand, and you can see that kind of pigmentation on the knuckles here. Routine laboratory studies were obtained, and his electrolytes were abnormal. His sodium was 126. His potassium was a little elevated as 5.6. His chloride was 92. His CO2 was 8, and his glucose was 65. Now, it's important to note, because we know, because I've told you that he has this, that he has adrenal insufficiency, that 20 or 30% of children who present with adrenal crisis do not have an elevated potassium. So you don't have to have an elevated potassium. You can just have a low sodium when you present like that. The symptoms of acquired adrenal insufficiency, because that is what he had, are nausea, vomiting, malaise, weight loss, muscle aches and pains. The signs are pigmentation of the skin and mucous membranes, as I showed you, weakness, decreased muscle and fat mass, and dehydration. And the laboratory studies that would be typical would be hyponatremia, hyperkalemia, and acidosis. Sometimes hypoglycemia, and he was heading in that direction. Now, adrenal insufficiency can be divided into a bunch of categories. It can be congenital, and if it's congenital, it can be primary. That means localized to the adrenal gland, or secondary, a problem with the hypothalamus or pituitary. It can be acquired, and that once again can be primary in the adrenal gland, or secondary, localized to the hypothalamus or pituitary. Congenital adrenal insufficiency can be related to primary adrenal destruction because of a vascular accident before birth or tremendous stress, adrenal hyperplasia because of various genetic etiologies, or can be secondary to hypothalamic pituitary dysfunction, usually of a genetic etiology. Acquired adrenal insufficiency, when it's primary and related to adrenal disease, is most usually autoimmune adrenalitis. In the old days, what Dr. Addison described was probably tuberculous destruction of the adrenal gland, and we still sometimes see this. In boys, one does have to worry about adrenal leukodystrophy because that makes up about 10% of the cases of acquired adrenal insufficiency in the first 20 years of life. Secondary adrenal insufficiency is related to hypothalamic pituitary disease, or sometimes from exogenous suppression because someone's been treated with glucocorticoids for another reason. So if we look at the different categories, as I described them, primary or secondary adrenal insufficiency, we see that with primary adrenal, you get hyperpigmentation because ACTH increases, and perhaps MSH also contributes to this. It pigments the skin. You get hyponatremia and hyperkalemia because of aldosterone deficiency, and you get dehydration because of salt and water loss. You also can get hypoglycemia because of the cortisol deficiency, and cortisol deficiency causes a decrease in intravascular volume with a redistribution of fluids to the third space. In secondary hypothalamic pituitary adrenal insufficiency, you get normal or decreased pigmentation because of the ACTH deficiency. You can get hyponatremia, but sometimes you can even see hypokalemia. Usually the potassium is normal. And that's because with normal aldosterone production, what happens is because the intravascular volume is decreased, vasopressin is increased, and it's a kind of a syndrome of inappropriate ADH secretion picture, although it really isn't inappropriate. The vasopressin is doing what it's meant to do, which is to hold fluid in the body. And that causes volume expansion and gives you the hypokalemia. You can also get hypoglycemia because of the cortisol deficiency. Now, in primary adrenal insufficiency, in the morning, the cortisol is decreased and the ACTH is increased. So you can make the diagnosis sometimes just with a single morning laboratory study where you measure ACTH and you measure cortisol. And if they have all those signs and symptoms and the cortisol is low and the ACTH is up, that's really all you need. In secondary adrenal insufficiency, you would expect in the morning that both the cortisol and the ACTH would be decreased. And often, in order to be sure, you need to do an intravenous synthetic ACTH test. Now, there are two ways to do this. One is using a high dose of synthetic ACTH, and that high dose is 250 micrograms per meter squared of body surface area, up to a maximum of 250 micrograms. That's the adult dose. And you measure cortisol at 0 and 60 minutes after doing this. An adequate response, well, there's lots of people worrying about what an adequate response is, kind of like figuring out how many angels dance on the head of a pin. I've selected a number which many people feel is right, but somewhere in this range is probably okay in terms of protecting the individual from adrenal insufficiency during stress. And that would be a cortisol at 60 minutes of greater than about 20 micrograms per deciliter. The low-dose test has been shown to be rather effective at picking up people who have mild adrenal insufficiency, and it uses a really low dose of ACTH, although it's enough to stimulate cortisol release in normals. 1 microgram per meter squared is given. Some people will give 1 microgram per 1.73 meters squared. Some will use 0.5 micrograms, but somewhere in this range, which is tiny. You give it, and then you measure cortisol not only at 0 and 60 minutes, but also at 30 minutes, because sometimes the 30 minutes is the best response. And most people feel that an adequate response is a cortisol of 18 micrograms per deciliter or better at 30 or 60 minutes. Some people will say 17, some people will want a little bit more or less, but in that range seems to be adequate. Now, our young man, who we described, had a very high ACTH and a low morning cortisol, and was treated appropriately and did very well. The story that I wanted to tell you, which is something that I always have to remind myself about, it was many years ago, and I forget that people have families. We studied him and found out he had adrenal antibodies, and so he had the autoimmune kind of disorder. And one day, about 2 years later, I saw his mother sitting in the waiting room of the hospital in January, and I looked at her and she said, "Did you just come back from Florida?" And she said, "Oh, yes, I just did." And then she called me a few days later and she said, "Do you know why I didn't go into the waiting room with you?" She said, "I used to think you were wonderful because you diagnosed my son, but I couldn't move because my muscles hurt so much. It was true I just came back from Florida, but that wasn't a tan. I have adrenal insufficiency too." So do remember that this does run in families. So, primary adrenal insufficiency, the first thing you do is look for adrenal autoantibodies, and sometimes you need to check for other autoimmunity because these people may be hypothyroid or some other thing. And in boys, it's very important to always check very long-chain fatty acids because adrenal leukodystrophy is not that rare, and you may have adrenal myelodystrophy, which just affects the muscles, not the brain, and that may even be more common. So it's most important to do this. This is a sex-linked disorder, as you know, although the women, the mothers, will have some milder effects. Secondary adrenal insufficiency, unless you know for sure the etiology is adrenal suppression with exogenous glucocorticoid, that person needs to have a hypothalamic pituitary MRI because they are likely to have hypothalamic pituitary damage that's visible, and they need measures of other pituitary function as seems appropriate under the conditions. In primary adrenal insufficiency, the most important thing to do is to get these people treated. And usually maintenance therapy is hydrocortisone replacement in the range of 5 to 10 milligrams per meter squared of body surface area a day. With hydrocortisone, we need to give it about 3 times a day because it's very short-acting. You can use a hydrocortisone equivalent, one of the synthetic glucocorticoids if you would like. People who have primary adrenal insufficiency and also lose mineralocorticoid function need replacement with mineralocorticoid. The only mineralocorticoid we have available to give orally is 9-alpha-fludrocortisone, and this is a synthetic drug which works very much like aldosterone. The dose varies from about 0.05 to 0.2 milligrams every day in young people and in adults. Babies sometimes need a lot more, and sometimes it's better to give it twice a day. Because cortisol itself has a little bit of mineralocorticoid effect, if you're using a synthetic glucocorticoid to treat the person, they may need a higher dose of fludrocortisone. So, for instance, if you have someone who's been receiving, cortisol 3 times a day, and then they switch to prednisone twice a day, their fludrocortisone need may go from 0.1 milligram a day to 0.2 milligrams a day. You really have to look for that, though. And you do that by checking plasma renin activity levels. In these people, ACTH levels in the morning and plasma renin activity are the best way to assess control aside from clinical condition, growth, and appearance. In secondary adrenal insufficiency, hydrocortisone replacement is also about 5 to 10 milligrams per meter squared per day. Sometimes you can get away with giving it only twice a day because these folks don't need mineralocorticoid and they're in general milder, but many times they need to be treated 3 times a day as well. So here's an important thing to know, which is the different glucocorticoids that we commonly use and what their actions are and their potencies. So hydrocortisone, or cortisol, has the potency of 1. Its duration is rather short, only 4 to 6 hours. So when we're giving it 3 times a day, we're leaving a patient without a lot of glucocorticoid for pieces of that day, and we're certainly not matching the usual diurnal rhythm, which is to have very low levels at midnight and then to have slowly rising levels with the highest levels in the early morning hours. Hydrocortisone has some mineralocorticoid effect. It's been variably suggested that 100 milligrams of hydrocortisone is about equivalent to 0.1 milligram of fludrocortisone. Prednisolone has a potency of about 5. It's about 5 times more potent than hydrocortisone. Its duration is longer, about 8 to 12 hours, and it has essentially almost no mineralocorticoid effect. Prednisone, which has to be converted to prednisolone in order to be active, is a little bit less potent. That's 1 to 4. And it has the same duration as prednisolone. It has minimal mineralocorticoid effect as well. And then finally, dexamethasone, which lots of people would like to use and is used in adults a bit. Dexamethasone was a very special medication designed for the potency of its anti-inflammatory effect. And most of the time when you look at these relative potency charts, they're looking at anti-inflammatory effect, not the other effects that we want out of hydrocortisone when we're treating adrenally insufficient people. And that means that the potency is somewhere between 40 and 80, somewhere in there. It may vary. So it's a very potent drug, and that means you need very small amounts of it, and it's very hard to titrate. Its duration is 24 to 36 hours, although there are people who actually need to get it twice a day because they have very short half-lives and rapid turnover of the dexamethasone. It has absolutely no mineralocorticoid effect, and people taking dexamethasone will need much more 9-alpha-fludrocortisone. So, following glucocorticoid suppression, which is the story that you guys usually see, you have to figure out how you deal with that adrenal insufficiency. And I know it's one of the consults that we get very often. And it's a consult that to us has to be divided into 2 pieces. So here's a case. You're caring for a 6-year-old boy who's diagnosed with inflammatory bowel disease, and he's receiving high-dose glucocorticoid treatment for his IBD. His gastroenterologist will be planning to use a new non-glucocorticoid therapy and wish to wean him off the glucocorticoids, and they ask you to take charge of that. So how are you going to do this? Well, your goal, of course, is to reduce the glucocorticoid to the lowest replacement dose as soon as possible. But the rate of decrease in glucocorticoid has nothing to do with how much cortisol someone needs for life. It's based on the response of the underlying disease. So if this person had no underlying disease left, you could drop it down to maintenance the next day and they really would not have very much problem. When we see someone with Cushing's disease and they've had surgery which treats them, we put them on maintenance the next day, and most of them don't complain at all. Some of them have gotten used to a slightly higher dose and want just a little bit more, and they say they're a little bit achy until they get it and they need to be weaned a little bit slowly. But most of the time, when you're reducing the glucocorticoid, you're doing it for the underlying disease, not because of the need for glucocorticoid. So you also have to distinguish between maintenance and stress needs for glucocorticoid, because someone like this may be able to get down to maintenance pretty quickly, but they might not be able to respond to a big stress, and they may need more glucocorticoid if they're exposed to the stress of surgery or illness of some kind, and that's most important to remember. So, when the underlying disease permits, you reduce the daily glucocorticoid dose to slightly less than maintenance, just to give the person a chance to sort of get their own adrenal function back again. And the ACTH will come back first, and then the adrenals will come back. 5 milligrams per meter squared hydrocortisone equivalence is about in that range. That will work. With a patient receiving cortisol or prednisone or prednisolone, if you omit the evening dose and measure the morning cortisol, you can get an idea of how well your plan is working. If the cortisol first thing in the morning, if they haven't gotten steroids since the day before, is greater than 10 micrograms per deciliter, you can basically stop the glucocorticoid for all intents and purposes. You don't know whether they'll need stress treatment because you don't know how they'll respond to the stress of a rising ACTH in response to surgery or illness, but they're going to be fine from day to day, and you could just tell them when they get sick they need to take double or triple the amount of medication they were taking before, and they might need to know about Solucortef, hydrocortisone hemisuccinate, which can be given parenterally. If you want to not have to go through that step, you can perform an IV ACTH test for safety. If the IV ACTH test, as I described, is normal, then you know the patient won't need stress glucocorticoid, and they're fine. They can just go about their business. Now, it is kind of funny to think about why you would use ACTH to test whether or not someone can release ACTH and the axis works. But the truth is that it works very well, and the reason is that if the adrenal gland has not been exposed to ACTH for a period of time, it becomes atrophic and doesn't respond. So the response to ACTH tells you that that adrenal has had good exposure recently, and the whole axis is okay. There are fancier tests looking at that, but this one really is the best. So that's the short form of adrenal insufficiency. I'd like to switch goals here a little bit and talk about the other end of the adrenal spectrum, and that is adrenal hyperfunction. And this is uncommon in childhood, but it does occur, and it's important that we all recognize it and know how to recognize it early. So this is an 11-year-old girl who is a real person who I saw, who appeared in my office, but she's appearing in your office for her routine well visit. You'd noticed a bit of weight gain the year before and had counseled her on nutritional changes and exercise. She's continued to gain weight, and when you measure her, you see that she's only grown 1.5 centimeters in the past year. And she's not yet reached menarche. She's in early puberty, stage 2. She should be growing well at that point. Also, her blood pressure is a little funny. It's 120/80. Her mother tells you that she's been having trouble keeping up with her friends physically. She tires easily, and she's lost interest in sports, which used to be her passion. On physical exam, you notice that she has a round face and a bit of a fat pad on her posterior neck. She has decreased muscle mass in her arms and legs and a centripetal sort of central body fat distribution. Not very much fat. She's working very hard to not get too fat. She's had a few striae on her abdomen, on her legs, but they don't seem very violaceous to you. She has a number of small bruises and says she bumps into things and bruises all the time. She has fine villous hair on her face and has no other evidence of androgen excess. This really doesn't look like androgen-stimulated hair. So this is a young lady, and you can see her growth chart as was given to me by her pediatrician. And one of the things you see is that it looks as if she had her real growth slowing only in the past year. But if you look back, she was growing up here between the 75th and 90th percentile, and maybe over the past 3 or 4 years she's had some shift in her growth rate. And even with her little Zorro mask on, you can see that back here this was a normal, rather thin child, and she's become progressively rounder in the face as time went on until at 11 years of age she's quite round and a bit Cushingoid appearing. And you can see that her big weight gain, although it was happening slowly, was really in this period of time when she stopped growing. So there was some sort of progression there. So you see her and you think you better do some screening studies, and you get some normal studies. Her thyroid tests are fine. Her complete blood count is fine. Her complete metabolic panel is fine. She doesn't have anything wrong with her liver or kidneys. And you do get a urine-free cortisol because you kind of are note that there might be some problem here. And her urine-free cortisol comes back as 150 micrograms for 24 hours with a normal less than 36. This is very high. There are stressed, unhappy, or depressed children who can have levels that are twice or even 3 times normal, but not this high. This is high enough that even with that single value, if it was collected properly, you probably have yourself a diagnosis of Cushing syndrome. So the symptoms and signs of Cushing syndrome are weight gain, increased appetite. People with Cushing syndrome don't gain weight because they're saprophytes and they absorb calories out of the air. It makes you hungry if you have extra glucocorticoid in your body and you eat more. You can't violate Newton's laws, okay? They'll have muscle weakness and some loss of muscle mass. Some folks with this condition will have trouble walking up and down stairs, and they definitely will have trouble with their sports activities. They may develop centripetal fat, and the posterior neck fat pad is more related to some loss of muscle mass. The skin may be a bit thinned, and that leads to the development of striae, although in children, striae don't happen until they've had severe Cushing's for quite a period of time. They'll have a round face. Headache may be prominent. Many will have borderline hypertension or true hypertension. And if this disorder is Cushing's disease, that is, it's related to elevated ACTH from a small tumor in the pituitary, you'll see the same kind of skin pigmentation that you see in Addison's disease. And then, of course, the most important thing, and we're lucky in pediatrics about this, you see growth attenuation, because someone who makes too much cortisol is going to stop growing. In adulthood, it's much harder to make this diagnosis because there is no growth attenuation. But if you have a child within the growing years whose growth has slowed when it shouldn't slow, that's a very important sign. There are only 3 endocrine disorders that are associated with growth attenuation: hypothyroidism, Cushing's disease, and growth hormone deficiency. So there's not a lot of them to worry about. So this is the problem, of course. As the artist Botero pointed out, we live in a world of obesity. Families are fat, pets are fat, mothers and fathers and all children are obese, and therefore there's so much obesity that we're seeing in our offices. It's hard to select out the children who should be screened further for Cushing disease, and so you have to have a high index of suspicion. And you happen to be looking very closely at the growth charts, because children who are obese, who have exogenous obesity, will not have growth attenuation. They will actually be growing a little bit better most of the time. So the appropriate laboratory studies for Cushing syndrome to rule out or rule in Cushing syndrome are 24-hour urine-free cortisols or salivary cortisols. The 24-hour urine-free cortisols, if you get 2 of them, usually you're pretty safe. If you're not quite sure, sometimes you need to get more because you can have intermittent Cushing's. Salivary cortisols, the internist will tell you have to get them at midnight. That's a hard thing to do, and there's been a very good study in children that came out of NIH a few years ago, which demonstrated that any time between 7 p.m. and midnight is fine, and you can get a couple of those. If those demonstrate Cushing's on a few samples, you can be pretty sure that you have adrenal excess. What I would not suggest you do are any random serum cortisols. They're really not very useful. And although some people think an overnight dexamethasone suppression test is good, where you give a half a milligram or a milligram of dexamethasone at midnight and then get a blood sample at 8 in the morning, that's a tough thing to do in a non-hospital situation. You have to be sure they actually took the dexamethasone. They have to get over to a lab in time. So I don't tend to use that test. Now, the only reason for getting a serum cortisol in this situation is first thing in the morning, if you get a cortisol and an ACTH, and the ACTH is not suppressed, if that's a nice measurable value, this then is Cushing's disease and not Cushing syndrome. It means that the pituitary gland is driving the process, and it makes your diagnostic studies a little bit easier. So, Cushing syndrome is of diverse etiologies. We've talked about pituitary Cushing's, which is actually Cushing disease. It's what Harvey Cushing described. You can have an adrenal carcinoma, as this young lady did, and she has more hirsutism and a little bit more viralization than someone with Cushing syndrome would have. You can have congenital Cushing's, as this baby does, and this was a McCune-Albright baby who started off with congenital Cushing's. And you can also get too much glucocorticoid in one way or another. This is a baby I saw some years ago. She was a 3-year-old who apparently presented with some respiratory distress to a neighborhood clinic. And the neighborhood clinic put her on dexamethasone for her asthma. The mother was not an English speaker. And the kids started eating fabulous amounts of food and gaining weight and looking like this, and the mother was getting increasingly worried. And she kept bringing her to various health centers around town and trying to explain in her Spanish that the baby was getting this medicine and she was getting too fat, and they kept saying, oh, you're feeding her too much, she's eating too much. And finally, someone looked at the bottle and saw that she was getting dexamethasone drops in a fairly large amount. And so I weaned her down off them after I saw her. And the mother called me in dismay one day and told me that her daughter had nausea. And I thought, oh my God, she's got adrenal insufficiency. She's been suppressed for so long. This is just terrible. I had her rush in to see me with the child, thinking I would see a little baby who was blue and in shock. And then the mother explained what nausea was. She was no longer eating 3 tortillas for lunch, only 1. So sometimes you need to ask more questions. But she did very well, having been weaned off her dexamethasone drops. So the differential diagnosis of Cushing syndrome is listed in this chart. Differential diagnosis relies on a number of things. Let's look at age first. Pituitary Cushing disease in children who are over the age of 7, greater than 70% will have pituitary Cushing's. Adrenal excess with a primary adrenal disorder is much more common in infants and younger children. And ectopic corticotropin releasing hormone, or ectopic ACTH, which can be released by various unusual tumors in adults. This is usually a small cell tumor of the lung. In children, it may be various neuroendocrine tumors in other locations, sometimes in the lung, sometimes in pancreas and other tissues, is rather rare. It's about 1% of all Cushing's in young people, and it's a bit more common in adolescents, but that means it's about 1% in adolescents because it's practically 0 in almost everybody else. Symptoms and signs are a little bit different among these. In pituitary Cushing's, there should be only minimal virilization, and you should get that funny pigmentation from the ACTH. In adrenal excess disorders, you may have virilization because the adrenals may be making lots of their preandrogens. They're like DHEA, DHEAS, and androstenedione. And you won't get the pigmentation because the ACTH has been turned off by the feedback. In ectopic CARH or ACTH, many of these are quite severe, and you'll have more extreme symptoms with hypokalemia and hyperpigmentation, but some can be quite subtle and not severe. So what are the diagnostic studies that will help you differentiate among these? In pituitary Cushing's, as I pointed out, the ACTH and cortisol in the morning will both be elevated, and that tells you that you need to look at the pituitary gland to make sure that this is pituitary Cushing's. The classic way we do this now is you get an MRI and you hope you're going to see a small microadenoma. Often you don't. And then you're going to do something called an inferior petrosal sinus sampling. And this is a venous catheter which is placed usually in the groin, threaded up through the heart, into the neck, and close to the petrosal sinus, into the petrosal sinus, so you actually can get the runoff from the pituitary gland. You do it on both sides. The invasive radiologists are very good at doing this. The patient receives a dose of corticotropin-releasing hormone, and simultaneous blood samples are taken from both of these petrosal sinuses and also from the periphery. And then you wait and see the response to the corticotropin-releasing hormone. There should be a big burst of ACTH. And if the burst of ACTH is found in the sampling from the petrosal sinuses, you know this is coming from the pituitary. If the burst of ACTH is just as high peripherally, then you've got to go looking for an unusual small tumor somewhere, which is an ectopic CRH-producing or ACTH-producing tumor. Now, these often look like they're localizing, so that there's much more coming out of one side than the other, but this is often just related to the vascularity of the pituitary, and you really only have about a 70% chance of being right. It's close to 50-50 whether you're going to be right because there's more release of the ACTH from one side than the other. But at least given that information, a skilled neurosurgeon is ready to go in transsphenoidally, usually through the nose or under the upper lip, and take a look at the pituitary and see if the surgeon can find a very small tumor. With adrenal excess, the cortisol will be elevated and the ACTH will be totally suppressed. You will not be able to measure ACTH. Adrenal androgenic precursors like DHEA, DHES, and testosterone may be elevated. And imaging of the adrenals usually gives you a good answer, so you want to do that. And whether that's ultrasound or MRI is where you usually end up, or radio imaging will depend upon what you find. Ectopic CRH or ACTH is very rare. In this case, the ACTH and cortisol will be elevated. The IPSS will not localize to the pituitary if it's ectopic ACTH, but it will localize if this is ectopic CRH, which is very, very hard to figure out. So if there's something suspicious about what you're seeing and you really think it's ectopic CRH, I mean, this is very, very rare. You can image for other tumors in other areas, but most of the time the neurosurgeon will get to the pituitary before you start trying to figure out, my gosh, maybe it isn't that, maybe it's something else, and these are very, very hard to diagnose in children when they occur. So, Cushing syndrome treatment. Harvey Cushing said we should be taking out those pituitary tumors, and people laughed at him for years because this was rather hard to do in the days before good anesthesia, et cetera, et cetera. Children with and adults with pituitary Cushing disease should really be treated at an established center to get the absolutely best outcome. You need very good neurosurgeons who do a lot of transfemoral work. With good transfemoral surgery, you get a 90+% initial cure rate in the children. It's 95-ish in adults, and usually no other endocrine loss. In children, unfortunately, there's a 20 to 25% recurrence rate, and that's higher than in adults, which is only about 5-ish or 10-ish%. It may be that there's something more virulent about these little tumors when they occur earlier. We really don't know. And I'm not talking about a recurrence rate 2 weeks later. I'm talking about several years later, that they just tend to have a greater risk of recurrence. If there is recurrence or the first surgery doesn't lead to an initial cure, often there may be a suggestion for repeat surgery, and depending upon the anatomy, the neurosurgeon may go in again and try to deal with this. Second time around, there may be more pituitary damage. Radiotherapy is also effective, and you can use proton beam and other localizing approaches to specifically define radiotherapy just to the pituitary gland. Anterior pituitary dysfunction will occur with time when this is the method of treatment. In some situations, you really have no choice, and you have to go after the end organ, which is affected rather than what's causing the effect, and you have to do an adrenalectomy. Adrenalectomy is very effective initially, but it may lead to pituitary overgrowth and so-called Nelson syndrome, where you get a big pituitary tumor because the end organ has been taken out. That's why usually when an adrenalectomy is done, radiation is done at the same time so that the pituitary is not likely to do this, but it still can be seen. If you have ectopic ACTH or CRH production, which as I said is incredibly rare, you have to identify the tumor, and that's sometimes hard to do. Surgical removal can be curative if you can get it all out. That's not always possible. With adrenal Cushing syndrome, I'm sorry, that should not say disease, it should say syndrome. That may be related to adrenal hyperplasia, and this can be secondary to a number of genetic activating mutations, or it can be related to an adrenal adenoma or carcinoma. The differentiation between adenoma and carcinoma in young people often relates to size. The larger tumors are more likely to behave like carcinomas, and some of the smaller ones are resected and there's no problem ever again. The treatment is adrenalectomy. Chemotherapy is not remarkably effective for adrenal carcinoma. There are some adrenal hormone blocking drugs that can be palliative. So what I'd like to do now is just to go back and remind you all in this land of obesity that you really do need to be looking. Here's a misdiagnosis for 1, 2, 3, 4 years. Good doctors. They saw an obese little girl and were always counseling her nutritionally, and it took until they realized she really was barely growing in 8th grade for them to look a little bit beyond that, and you can see, even with her little mask on, that she was quite Cushingoid, even back in 5th grade. Here's fraternal twins who took a long time to make the diagnosis. As you can tell the difference in their height. And you can see back here the difference between the boy without and the boy with. He's quite a bit shorter. Now, the other interesting thing is they both had asthma a few years before. His asthma went away and his stayed. After he was treated for his Cushing's, the asthma came back right away. So the exogenous cortisol, the endogenous cortisol he was releasing was doing a good job on his asthma. And you can see in this boy that same sort of dark knuckles. This is compared with his brother. As you saw in that other child, he has some of that pigmentation on his knuckles. And you can tell he's the patient because he's got the bracelet on his wrist. So these are the kind of Cushing's striae that you read about and you think you're going to see in people with Cushing's. And this was a young man who probably had Cushing's for 6 years, and he had amazing striae and was left after treatment with amazing folds of fat with striae. But this is actually very uncommon in children, a bit more common in adults. But you can see it. He was about 19 in that picture. So the big problem here is here's an attractive young lady with Cushing's, and here she is 2 years later without her Cushing's. She's back cheerleading. She's doing everything she wants to do. But, you know, when you've had Cushing's for a period of time, you're left with some chronic residua. Physical recovery from Cushing's is not complete. You may have depression and learning disabilities. This has been well described, and that can last for several years. I had one young lady who was very introspective and an artist say to me at 14 that after she'd had her treatment for Cushing's, she knew she looked better, but she had lost her creativity, and it took her 2 years to regain it. She really felt terrible about that. You also can end up with metabolic syndrome. A lot of these folks will go on to continue to have hypertension and body fat distribution, which is typical of metabolic syndrome. So the point is, making the diagnosis early, treating them early is all to the best for their whole life futures. So this is a quote which I'd put up here so that we all don't feel too guilty about our misses as well as our successes. And this is from Findling and Rath from an article they wrote in 2001. Clinicians who have never missed the diagnosis of Cushing syndrome or have never been fooled by attempting to establish its cause should refer their patients with suspected hypercortisolism to someone who has. This is a very difficult diagnosis to make, and if you haven't missed it once or twice, you probably don't know that you've missed it. So I'm going to switch gears now and talk about the other adrenal problem, which we pediatricians worry about, and that's congenital adrenal hyperplasia. So here's a little case history for you. You receive a message from your local newborn screening program that a baby born 6 days ago who's just joined your practice has an elevated level of 17-hydroxyprogesterone on the newborn screen. Normal values are up to 30 on the filter paper screen, and the report you get is that the new baby has a value of 83, which is high. You see the boy that afternoon, knowing this is an emergency, and of course it's always Friday afternoon, isn't it? And he looks happy and healthy. He was a full-term, unstressed delivery with normal genitalia, has no increased pigmentation. That's pretty typical. His birth weight was 3,000 grams, and maybe the only thing that you should think about a little bit is he still weighs 3,000 grams at 6 days. That happens, but, you know, no weight gain at all. His mother says he's breastfeeding well, which means, you know, who knows how much he's taking. You obtain a blood test for electrolytes and 17-hydroxyprogesterone. The electrolytes come back with a sodium of 134. In another baby, you might not think anything of that, although it's less than 140 for sure. Potassium is 5.6, but babies are always slightly hemolyzed, and there was a question that this was slightly hemolyzed. Chloride is 96, the bicarbonate is 17. So all in all, you've seen those values before, but in this particular baby, those values have to make you feel a little nervous. So you're good about it. You admit this patient to the hospital and you let the endocrinologist know about the baby. Newborn screening lab confirms that the repeat heel stick that you send out, because they can turn around in 24 hours, was 112. So the 17-hydroxyprogesterone is really elevated. Infant still looks well, but you send a 17-hydroxyprogesterone off to a central lab. You're not quite ready to commit to much more than just watching this baby, and the parents are totally bewildered by the fact that you're just staring at this baby and not doing much. In 2 days, the 17-hydroxyprogesterone returns as 25,000 nanograms per deciliter. Normal is less than about 150. So this baby definitely has congenital adrenal hyperplasia, and with a value like that, it's likely to be severe and salt-losing. So you start the child on glucocorticoid. Now we have a problem. The problem is that hydrocortisone, cortisol, comes in tablets. And it's hard to give exactly the amount you want when the smallest tablet is 5 milligrams. We used to have a liquid preparation of hydrocortisone. We don't anymore. Some people will find a compounding pharmacy to grind up tablets and distribute small amounts of hydrocortisone. But these kids actually do pretty well on prednisolone, and you know there is a prednisolone suspension preparation you can use. You just have to be careful about the dose. And then you can also give it twice a day, which is sometimes easier on the family. So you give hydrocortisone equivalents of prednisolone of 25 milligrams per meter squared for 3 days. I'm sorry, that's an error. And then 10 to 15 milligrams per meter squared thereafter. You add 9 alpha-fludrocortisone, 0.2 milligrams per day, because you know babies have a lot of salt wasting, and this baby is not getting any hydrocortisone, so probably needs a bit more 9-alpha-fludrocortisone. The mother's breastfeeding, so the baby's not going to be getting very much salt, and you're going to probably need to adjust both of these medications. You may need to give more mineralocorticoid initially, and you're probably going to have to give the baby a salt solution, which it will hate but need several times a day. So here is congenital adrenal hyperplasia in a nutshell. Here's all the steroid pathways laid out. And we're really talking about the block over here in CYP21 or 21-hydroxylase, right over here. So when you have this block, you can't go from 17-hydroxyprogesterone down to 11-desoxycortisol, which then gets converted to cortisol, okay? And that block, which also, if it's severe, occurs in the mineralocorticoid pathway, does not allow you to go down to aldosterone. So everything gets shunted in this direction, and you make lots of androstenedione, DHEA, and eventually testosterone, and even some estradiol. That's the most common, about 95% of babies. Probably the next most common is the 11-beta-hydroxylase down here, and in that situation, you can't make cortisol, and you can't make aldosterone. But interestingly enough, you can make desoxycorticosterone, which is a very good mineralocorticoid. So you end up with the same masculinization of the females, virilization of the females, and often with a little bit of hypertension as time goes on. But as soon as you treat these children, you block all of this, and the children become salt losers also. The other disorder which we can see on occasion is the 3-beta-hydroxysteroid dehydrogenase, which is the one right over here. And that kind of blocks everything. So you end up with boys who aren't too well masculinized and girls who are a little bit masculinized. It's kind of a mixed picture. But it's very, very uncommon. And they are salt wasters, almost all of them. So CYP21, or 21-hydroxylase deficiency, is the most common type. 95% of all children with congenital adrenal hyperplasia have this. 11-beta-hydroxylase deficiency and 3-alpha-hydroxysteroid dehydrogenase and isomerase, as I said, are probably the next most common. CYP21 deficiency has an incidence of about 1 in 12,000 to 1 in 16,000 live births in the United States. If you happen to be working among the Yupik Eskimo, it's about 1 in 700 because there's a founder effect up there and a lot of children have it. Screening, the newborn screening, which is across the entire United States now, identifies almost all the affected children in the newborn period. Before screening was universal all across the world, there was a lovely paper published from the British Isles describing the fact that screening probably wasn't necessary because the children were all being identified, but they were identifying 2 girls for every boy, which means that there was 1 boy dying because it should be 50-50 girls and boys. So the girls are identified because they look different, and the boys are missed and they die from what seems to be gastroenteritis sometime later. Now, so there are problems with newborn screening, though, and you all may see those problems with the babies who you end up following. There's a lot of false positives in stressed premature babies. So stressed prematures, they usually set a higher level for, but it's important to remember that stressed premature infants can have congenital adrenal hyperplasia, and I follow a couple of kids where it took a while to sort that out, and the children were actually receiving saline because they were felt to be just salt-losing stressed preemies, and they really had congenital adrenal hyperplasia. So keep in mind that these are not mutually exclusive. A positive screen is certainly an emergency. It usually takes 5 to 7 days to return, and you could have symptomatic salt wasting by 7 to 10 days, although it may take a little bit longer. So in terms of prenatal counseling, when you know that somebody has one child with this condition, or you know there are relatives with it, 1 in 4 infants born to 2 carriers are going to have congenital adrenal hyperplasia, and 1 in 2 will be a carrier. But only 1 in 8 will be a female infant with congenital adrenal hyperplasia with potentially virilized external genitalia. So it's not a large number who will potentially need corrective genital surgery. The severity of the congenital adrenal hyperplasia in the infant is also determined by the least affected parental genotype. By that, I mean that if one of the parents has the really severe kind, it doesn't mean the baby necessarily will if the other parent has a mild kind. So if one parent has a deletion in the gene and would then have a very severe kind, but the other has a very mild late-onset CAH gene, the infant is going to have mild late-onset phenotype. All you need is to look at the gene which is least problematic, and that's what the baby is likely to look like. So there has been, over the years, some rush to consider prenatal treatment to prevent virilization in the female fetus. You can give the mother a load of dexamethasone as soon as it's recognized that she's pregnant, and stop it as soon as you know that the mother is having a boy where it doesn't count, or you know that the mother has a child that doesn't have the disorder. And if you do that, the babies will actually be born with minimal virilization. The girls really will not need surgery. On the other hand, they may have learning disabilities, because when you block this, genes that will also be blocked by dexamethasone, which can get through the placenta because it's not destroyed by the placenta, you actually block some important developmental pathways in the brain. And so therefore I think that probably it's better to have surgery because of some virilization externally than to have to worry about your learning disabilities over the years. And I'm not the only one who feels this way, although there are still many pediatric endocrinologists who will suggest using this treatment prenatally to protect the little girls from needing genital surgery. So the presentation of 21-hydroxylase deficiency, I presented you with a boy, which is the one we most worry about because they're the ones who are missed, but this is what the little girls may look like. The girls usually have genital ambiguity, and this is a little girl who has a rather severe Prader 4 genital ambiguity with a clitorophallic structure and a cloaca, urethral cloaca just under the clitorophallic structure. And she will end up needing some surgery if she wishes to, if the family wishes to rear her as a female. I pointed out that the premature infants with CAH are vulnerable to misidentification. If not identified early, symptoms of adrenal insufficiency and salt loss by 1 to 3 weeks are common in the severely affected children. And what are those symptoms? Similar to gastroenteritis, failure to thrive, sepsis, poor feeding, vomiting, polyuria, dehydration, and shock. And when you get laboratory studies, you get a low sodium, a high potassium. Urine electrolytes will show a high sodium and low potassium because the urine is putting out sodium and hanging on to the potassium because of the absence of aldosterone. So if the gene is not so severe so that the mineralocorticoid pathway is not very affected, this is usually called simple virilizing adrenal hyperplasia. So there's an androgenic effect but not a mineralocorticoid effect. These children will usually be identified by screening, and the girls will have some virilization. Sometimes they're not identified if they're picked up later. This is a child before the advent of screening. The boys will look like they have isosexual precocity. This is a little boy who came in, and you can see he has a rather nice tan for January, February. That's from the ACTH. He was 6 years old. He was the height of a 9-year-old, and his bone age was advanced at 10. And if you examined him, you could see he had a rather large phallus. He had pubic hair. His testes actually were quite small because the androgen driving this was not coming from his testes. It was coming from his adrenals. The very late onset CAH will not be identified by the newborn screen. Children, girls will present with premature adrenarche or sometimes polycystic ovary syndrome pictures, and the boys will present with premature adrenarche, so they just have the pubic hair and they don't have the testicular development, etc. To diagnose this, you get a morning 17-hydroxyprogesterone, or sometimes you have to do an ACTH test. For many of the more severe ones, you don't treat them. The adults are short, and the females will have some virilization. Some people who have been diagnosed with this, though, seem to have very little in the way of symptomatology and go on without treatment. They just sort of look like women with PCOS, and the men are just do fine. So in terms of emergency medical management of CAH, children need to be given intravenous fluids, which should be normal saline with glucose and no potassium. They should be getting stress dose of hydrocortisone hemisuccinate intravenously, sub-Q or IM if you can't get it any other way, every 6 hours, and they should have their blood pressure and their pulse, their body weight, and their electrolytes monitored very carefully. They'll be treated quite quickly, and they'll turn right around if they're treated this way. If they're salt losing, you treat them with hydrocortisone, glucocorticoid 2 or 3 times a day, and they need a higher dose than people just with adrenal insufficiency, because not only are you replacing them, but you're also suppressing their adrenals, which are not doing the right thing. 10 to 20 milligrams per meter squared, or the equivalent in prednisone, and dexamethasone is sometimes used, but I think it's hard to control. They need 9-alpha-fludrocortisone to control salt loss. And they need double or triple glucocorticoid for physical stress, and the parents need to know how to give parenteral hydrocortisone hemisuccinate in emergencies, and they need to know what an emergency is and how to respond. With late onset, they don't need the mineralocorticoid, but they need the glucocorticoid as discussed, and they need to double or triple up their glucocorticoid for physical stresses. So this is a warning for all kinds of adrenal insufficiency, and I would just like to leave this in your minds. Children with adrenal insufficiency can lead healthy, normal lives with appropriate care, but they are really at increased risk of death or serious impairment because of adrenal crisis, and large population studies have demonstrated this. So a febrile illness, vomiting and nausea and adrenal insufficiency must always be treated immediately and sufficiently. The etiology of adrenal Cushing syndrome can be hyperplasia, which may be secondary to a number of genetic activating mutations, not all of which have yet been described, an adenoma or carcinoma. Differentiation between an adenoma and a carcinoma is often based on the size of the tumor. The larger tumors in general behave like carcinomas. Many of the smaller ones can be surgically resected, and there really is no problem thereafter. The treatment is adrenalectomy. Chemotherapy is not remarkably effective for adrenal carcinoma. Adrenal blocking drugs can sometimes be palliative if they're necessary. You start the child on prednisolone given twice daily, hydrocortisone equivalents of 25 milligrams per meter squared for 3 days, and then dropping the dose down after you've suppressed the adrenal gland a bit to 10 to 15 milligrams per meter squared. You add 19-alpha-fludrocortisone, 0.2 milligrams per day, because you know that babies make an awful lot of steroids which actually act to cause more salt wasting. So this baby will need more than the child will need as an adult. And the mother is breastfeeding, which means that the baby is getting very little salt. You're probably going to need to adjust both medications. And more mineralocorticoid, as I noted, will be needed initially. And you also will probably need to give extra salt as a salt-containing solution, which the baby will hate, but will take about 2 or 3 times.